What if the reason your patient's severe depression just isn't lifting is, well, actually because of their lower back?
Yeah, we see it in the clinic constantly, actually.
Right. I mean, a patient comes in with a major depressive episode. Um, you check the criteria, you code the DSM-5 diagnosis, and you build a treatment plan around that specific isolated mood disorder.
Exactly. And the standard models of care just break down completely when we try to cleanly separate psychiatric conditions from somatic ones like that.
But if you're a psychiatrist, a neurologist, or really any clinical provider listening to this right now, you already know the brain simply does not respect the neat little diagnostic boxes we draw on our medical charts.
No, it really doesn't. We send the localized pain to the pain management clinic for epidurals or gabapentin, and then, we send the mood dysregulation over to psychiatry for an SSRI.
Right, and in complete silos.
Exactly. But decades of neuroimaging and functional connectivity studies are telling us that treating these as two totally separate diseases is, well, it's a biological fiction. They're fundamentally woven together.
Which brings us to the core mission for our discussion today. We are looking at the deeply interconnected neural architecture of chronic pain and depression.
It's a fascinating area.
It really is. And for the providers listening who are already familiar with transcranial magnetic stimulation or TMS therapy, our focus today is heavily on the latest trends, the true clinical value, and where the future of this technology is actually heading regarding these overlapping disorders.
Because the landscape is shifting incredibly fast right now.
Very fast. Oh, and before we get into the heavy neuroscience, I want to explicitly mention that this exploration is brought to you by the Blossom TMS team at Sabres Medical.
They're doing some really incredible work in this space.
They absolutely are, and we'll talk more about their advanced platforms a bit later. But, okay, let's unpack this. Let's jump straight into the hardware.
Sounds good. Let's start with the basic overlap.
So we know that when a patient suffers from chronic pain, where the tissue damage healed years ago, but the centralized pain persists, and they also suffer from depression, the two conditions don't just exist side by side.
Right, they aren't parallel tracks. They actively amplify each other.
How so?
Well, the clinical reality is basically a localized echo chamber. Physical pain drives up the neuroinflammatory markers and the emotional distress, while the deepening depression literally lowers the body's mechanical pain tolerance.
Wow, so they feed off each other.
Exactly. And when we look at the functional MRI data of patients suffering from both, we see exactly why this happens. They are literally fighting over the exact same neural real estate.
Right.
We were primarily looking at the breakdown of three interconnected regions: the prefrontal cortex, the anterior cingulate cortex, or the ACC, and the broader limbic system.
Okay, let's break down how those three specifically misfire together. Because you have the prefrontal cortex, specifically the dorsolateral prefrontal cortex, acting as the executive control center, right?
Yep, the DLPFC.
It's the top-down regulator. It is supposed to exert inhibitory control over the lower brain regions.
Exactly, it's the brakes. And then you have the ACC, which is essentially the bridge between cognitive evaluation and emotion.
Right, it doesn't just process the location of the pain. Right?
No, not at all. It processes the emotional suffering of the pain. It's the region that decides a sensation is not just intense, but actually distressing.
That is such a crucial distinction.
It really is. And then, of course, you have the limbic system, particularly the amygdala, which governs the raw, fundamental stress and fear responses.
I was reviewing the connectivity maps in the source material, and a specific analogy came to mind.
Oh, yeah.
Yeah, it's like having your building's thermostat wired directly to the fire alarm system.
Oh, I like that.
Right. When the limbic system detects a stressor and starts sounding the alarm, it automatically forces the ACC's pain pathways to overheat. And because the prefrontal cortex, the system manager, basically is asleep at the wheel, there's nobody to reset the breaker.
That is exactly what happens.
Yeah.
What's fascinating here is that when you put a patient with this comorbid profile into a scanner, you see a highly specific resting state imbalance.
What does that look like on the scan?
Well, there is severe hypometabolism in the dorsolateral prefrontal cortex. Like you said, the system manager's offline, the regulatory brakes are gone.
Wow.
And simultaneously, you see hyperconnectivity and hypermetabolism
Yeah.
between the ACC and the amygdala.
So the alarm is just blaring constantly.
Blaring. The descending anti-nociceptive pathways, the systems that are supposed to release endogenous opioids to dampen pain signals, they're completely dysfunctional. because they rely on that top-down signal from the prefrontal cortex to even activate.
And if that fire alarm rings long enough, the wiring itself actually burns out and reconfigures, doesn't it?
Yes, exactly. Which brings us to the transition from an acute state to a permanent structural feature.
Right, neuroplasticity.
Yeah, we usually talk about neuroplasticity as this inherently positive mechanism, for learning and trauma recovery.
Right, cells that fire together, wire together, usually a good thing.
Usually. But in the context of chronic pain and depression, we are dealing with severe maladaptive neuroplasticity. Central sensitization occurs.
Because the brain is just relentlessly efficient. If the ACC and the somatosensory cortex are constantly receiving ascending pain signals or even just the emotional expectation of pain, the brain literally reshapes its synaptic architecture to become better at generating that specific response.
Exactly. It gets too good at feeling pain. We see an actual downregulation of inhibitory interneurons.
So the threshold for depolarization just drops.
It drops so low that the brain can generate a massive agonizing pain response to a completely benign physical stimulus.
That is terrifying for the patient.
It's agonizing. And the cellular environment itself changes too. Prolonged depressive states elevate cortisol and inflammatory cytokines.
Which is basically toxic over time.
Highly toxic. Over time, it physically damages the dendritic spines in the prefrontal cortex. You get actual cortical thinning.
Cortical thinning. Wow. So the top-down regulation that normally tells the brain, hey, this is just a minor ache, ignore it, is structurally compromised.
The neural loop is locked in anatomically.
So what does this all mean? I'm going to challenge that specific point because I know clinicians listening are thinking about this right now.
Go for it.
We've had medications for years that are explicitly designed to target this dual pathway. We use heavy-duty SNRIs like duloxetine or tricyclics combined with neuropathic modulators like pregabalin.
Sure, standard of care.
Right. So if the issue is a failure of descending inhibition, and these drugs increase synaptic serotonin and norepinephrine to artificially boost that inhibition, shouldn't those systemic medications be enough to break the neuroplastic loop?
You would think so.
Right. Why is the rate of treatment resistance in this specific population so incredibly high?
Well, SNRIs and gabapentinoids do work for a subset of patients, but they fundamentally hit a biological ceiling. Yeah, and that ceiling exists because of the difference between chemical symptom suppression and structural circuit correction.
Okay, unpack that difference for us.
When you prescribe an SNRI, you are flooding the synaptic cleft with neurotransmitters. But if the structural density of the dendritic spines in the prefrontal cortex has already been severely pruned back by years of depression and chronic pain.
The receptors just aren't there to catch it.
Exactly. Flooding the synapse is like pouring premium gasoline into a car with a missing engine block.
That is a great way to put it. You are basically turning up the volume on a speaker where the internal wiring is already frayed.
Yes. The medication might temporarily dampen the alarm by chemically muscling the overall nervous system, but it doesn't rebuild the dendritic spines.
It doesn't fix the localized network dysfunction.
Not at all. As soon as the patient builds a tolerance or attempts to taper off, the underlying maladaptive architecture is still sitting right there.
Because it hasn't changed.
Right. The hyper-efficient pain pathways in the ACC haven't been rewired, they've just been sedated.
Yeah.
You cannot fix a localized network connectivity problem by simply saturating the entire central nervous system with a chemical blanket.
Which really explains the major pivot we're seeing in modern interventional psychiatry.
Absolutely.
If pharmacology is hitting a ceiling because it can't drive targeted structural repair, we need a tool that does. And for the providers listening, this is exactly why TMS has moved from just a novel depression treatment to the absolute front line of circuit-based care for these complex, comorbid patients.
Yeah, we aren't relying on systemic chemical saturation anymore.
Here's where it gets really interesting. How does it actually work at the circuit level?
Well, we are directly inducing neuronal depolarization in the specific targeted circuits that are misfiring.
Right.
When we deliver a high-frequency magnetic pulse, typically a 10 hertz protocol to the left, dorsolateral prefrontal cortex Faraday's law of electromagnetic induction takes over.
So the magnetic field just passes painlessly through the skull.
Painlessly? Right through the skull. And it induces a localized electrical current in the cortical tissue. We are physically forcing those dormant prefrontal neurons to fire.
And it's not just a temporary electrical jumpstart, right? The mechanism of action is what drives the actual long-term clinical value.
Exactly.
Because when you repeatedly force those neurons to depolarize over, say, a 4 to 6 week treatment course, you are triggering long-term potentiation.
Yes, LTP.
You get this massive calcium influx at the cellular level, which activates the NMDA receptors, and critically, it triggers the release of BDNF, brain-derived neurotrophic factor.
And BDNF is the miracle protein in this equation.
It really is.
It is the fertilizer that actually drives structural neuroplasticity.
Hmm.
By upregulating BDNF release, specifically in the prefrontal cortex, TMS forces the brain to sprout new dendritic spines.
Oh, wow, so it's literal regrowth.
Physical rebuilding of the executive control center.
Yeah.
And as that top-down regulatory network comes back online, the cascade of clinical outcomes across the entire brain network is just profound.
You essentially give the brain its brakes back.
Yes.
As the prefrontal cortex regains its structural integrity, it resumes its normal job of inhibiting the hyperactive limbic system.
It quiets down the amygdala, which naturally lifts the severe mood dysregulation.
But because these circuits are functionally linked, that exact same top-down signal travels into the anterior cingulate cortex and begins dampening the emotional processing of physical pain too.
And the clinical validation of this shared circuitry is actually one of the most fascinating developments in the entire field.
Oh, the incidental findings, right.
Yes. If we look at the secondary reporting data from massive major depressive disorder trials over the last decade, we see an incredible pattern.
What were they seeing?
So patients were receiving TMS strictly on FDA-approved depression protocols. They weren't being treated for pain at all.
Right.
Yet time and time again, these patients were hitting remission for their depression and casually reporting to their clinicians that their severe fibromyalgia or their intractable lower back pain had dropped from an 8 out of 10 down to a 3.
Wait, really? Just from targeting the depression?
Just from the depression protocol. The physical pain faded because the network was repaired.
That is wild. They were aiming the magnetic pulses at the mood disorder, but because chronic pain shares the exact same dysfunctional real estate, treating one inherently treats the other.
Exactly. It is real-time clinical proof that symptom-based DSM diagnoses are really missing the underlying biological picture.
When you repair the network, all the downstream manifestations of that network dysfunction just naturally improve.
Right. And for the clinician managing a highly complex patient, someone who's severely depressed, in chronic pain, and likely already on a massive cocktail of polypharmacy, the clinical advantages of TMS are completely unmatched.
Unmatched. You are offering a highly aggressive, durable intervention that is completely non-invasive.
No anesthesia, no systemic absorption.
And zero systemic side effects,
Yes.
which is huge. When you are dealing with a patient whose chronic pain already leaves them entirely fatigued, the absolute last thing you want to do is introduce another sedating medication.
Exactly. With TMS, there is no medication-induced weight gain, there is no cognitive blunting, there is no gastrointestinal distress.
The patient just drives themselves to the clinic, receives a localized treatment that physically remodels their neural circuitry, and drives themselves back to work.
It is precision medicine in the truest sense.
It really is.
But, the field isn't stopping at the standard 10 hertz protocol.
No, definitely not.
The future of integrated care, and where the most advanced clinics are heading right now, is incredibly exciting. We are moving way beyond generalized left-sided stimulation and looking at highly optimized patient-specific parameters.
Yeah, the shift toward theta burst stimulation, or PBS, is a massive part of that future.
Huge part.
Instead of a 37-minute standard protocol, clinics are utilizing the natural firing frequencies of the hippocampus to drive even faster, more robust neuroplasticity. We're looking at intermittent theta burst, or ITBS, which is highly excitatory, delivered in rapid 3-minute sessions.
3 minutes. It's incredible. And we are utilizing bilateral targeting to address the distinct components of the comorbidity.
How does the bilateral protocol work for this?
Well, a clinician might apply excitatory intermittent theta burst to the left dorsolateral prefrontal cortex to rebuild the mood regulation networks.
Right.
Yeah. And then, in the exact same session, apply continuous theta burst, which is an inhibitory protocol, to the right dorsolateral prefrontal cortex, or the primary motor cortex.
To actively suppress the hyperactive somatic pain signals.
Exactly. You are simultaneously pressing the gas pedal on mood recovery and pumping the brakes on pain perception.
That is brilliant. And the targeting itself is evolving, too. We are moving away from the old standard 5-centimeter rule, where we basically just measured from the motor strip and guessed the optimal prefrontal location.
Oh yeah, the future is individualized functional mapping.
Using resting state fMRI to actually guide the TMS coil.
Because every human brain is folded slightly differently.
Right.
By putting a patient in a scanner before treatment, Advanced clinics can identify the highly specific subgenual anterior cingulate cortex, the SGACC, which is a major node for depression and pain processing.
And then what do they do with that image?
They map the SGACC's connectivity to the surface of the prefrontal cortex to find the exact, individualized anti-correlated node for that specific patient.
So you find the exact millimeter on the scalp that will exert the maximum inhibitory control over that deep brain dysfunction.
Exactly. You aren't treating a general region anymore. You are using neuronavigation to deliver a magnetic pulse to a specific neurological fingerprint.
Wow. Which drastically enhances the remission rates for patients with complex overlapping profiles who have essentially failed every other intervention.
But realizing this future requires a massive paradigm shift in how providers think.
How so?
If we connect this to the bigger picture, the technology is already here. The imaging data is undeniable. Clinicians have to stop treating chronic pain and depression as isolated, siloed events.
Right.
Treating the physical pain without addressing the structural breakdown of the mood network will fail. Treating the depression while ignoring the hypersensitive pain pathways, constantly setting off the limbic fire alarm, that will fail too.
So the integration of pain management and interventional psychiatry isn't just some progressive idea.
No, it is a biological necessity.
I want to turn that directly to you, the provider listening right now.
Yeah.
Think about your own patient panel this week. How often are you treating someone for severe treatment-resistant depression, constantly adjusting their SSRI dosages, maybe adding atypical antipsychotics as adjuncts, only to realize that their unmanaged chronic back pain or neuropathy is the invisible anchor completely preventing their neurological recovery?
You just cannot stabilize the mood if the descending pain pathways are structurally broken.
You can't.
That is the vicious cycle that modern TMS is uniquely designed to break. To sort of summarize the clinical reality we've explored today, chronic pain and depression are deeply intertwined network dysfunctions. They share the same compromised real estate in the prefrontal cortex, the ACC, and the limbic system. As those circuits dysregulate, the structural neuroplasticity becomes entirely maladaptive, locking the brain into a state of highly efficient suffering.
And because systemic medications often act only as chemical mufflers, they fail to drive the structural remodeling necessary for true remission.
Exactly. TMS steps into that gap as a biologically sound, evidence-based intervention. By utilizing targeted magnetic fields to induce long-term potentiation and BDNF release, it allows clinicians to shift away from endless symptom suppression.
And directly rebuild the dysfunctional circuits instead.
It restores the top-down regulatory control, offering sustainable long-term relief for patients who have essentially exhausted every conventional therapy available. It really is a fundamental evolution in how we practice psychiatric medicine.
It is incredibly exciting, and the technology enabling this shift is more accessible than ever. As a reminder, this critical clinical update on the true value and future of integrated neurostimulation was brought to you by the Blossom TMS team at Sabres Medical.
Highly recommend checking them out.
Absolutely. If you are a provider looking to integrate a clinically advanced TMS platform, one specifically designed to support the kind of precision brain stimulation, neuronavigation, and advanced protocols we discussed today to drive improved patient outcomes, you really need to connect with them.
Yeah, it's worth the call.
You can reach the Blossom TMS team directly by phone at +1.833.328.9867, or you can email their clinical integration specialists at sales@sebresmedical.com. And if you happen to be in the area, their headquarters is located at 230 S Broad Street, 17th floor, Philadelphia, PA 19102. Reach out to them. It will transform your practice.
Partnering with advanced platforms is really the only way clinics will be able to keep up with the rapid evolution of these circuit-based therapies.
Before we wrap up, I want to leave you with one final lingering thought to chew on as you head into your clinic tomorrow. We've thoroughly established that targeting the prefrontal cortex for major depression inadvertently, but significantly, reduces chronic physical pain. The neuroscience proves that the neural pathway is a two-way street. So if that is the case, and as our targeting becomes even more precise with individualized fMRI mapping, could the psychiatric clinics of the future eventually become the primary care centers for chronic pain management?
Oh, wow.
Are we looking at a rapidly approaching horizon that completely blurs the lines between psychiatry, neurology, and physical rehabilitation?
It's a huge question.
It's a wild thought, but the underlying biology suggests it isn't just possible, it's inevitable. Thank you for joining us for this exploration. Keep questioning the standard models of care and keep pushing the boundaries of interventional psychiatry. Have a great week in the clinic.